I'm so pleased to have these four people here because these are our practitioners who are working in this field, and I will briefly introduce them, and then what I will ask them to do is to each just speak for 1 or 2 minutes about how they actually try to work with mental health and physical activity. So addressing the last point that Guy made about bridging that gap between the mental health specialists and the exercise specialists. So I'm just going to step up onto the stage here. I always say this is my Oprah day. I feel like Oprah. I don't have her panache, though. Okay, so to my immediate right is Rachel Kieschuk, and Rachel is a registered psychologist and works with the very excellent Pediatric Center for Weight and Health at the Stollery Children's Hospital. And I'm sure she'll talk more about that program, but that is an excellent program. And to Rachel's right is Brenda Fishbrook-Benoit. Benoit, oui, sorry about that. And she's an occupational therapist, so really working in the physical activity, and works in geriatric psychiatry at the Glenrose Rehabilitation Center. And then to her right is Beth Evans, and Beth has a Master of Science in Applied Psychology and works for mental health promotion with Alberta Health Services in mental health and addiction. And then finally to Beth's right is Emma Rickard, and Emma, from her accent, has come from New Zealand and has also worked in England and Canada, so some similarities there with Guy. And she is a social worker and works in a number of social work settings, including mental health community services. So again, I'm just going to hand the microphone over to Rachel, and I'm just going to ask her to speak for just a few minutes about, again, how she works with mental health and physical activity to try to bridge the gap. And once we are done that, we will open up the floor to questions. So maybe some of the questions that we didn't have time to address this morning, if it works, if your question is appropriate for this panel, please feel free to jump up. Again, we'll ask you to go to the 2 microphones because we are recording this for the people who are unable to come today. So I will pass it over to Rachel.
I always seem to pick the wrong chair and wind up having to go first. So as Tanya mentioned, I'm the psychologist for the Pediatric Center for Weight and Health. Through the Stollery, we're at the Edmonton General site now. For those of you who aren't familiar with us, we're a multidisciplinary team, and we work with kids generally between 8 and 17 who are overweight, but we work with the kids and their families. We have dietitians, we have exercise specialists, pediatricians, nurses, community liaisons, and an entire research crew. And one of the nice things for me as a psychologist is this is the first time I've actually been able to interact with exercise specialists, which in the past I've always known the importance of exercise, especially for things like self-esteem in kids and depression and anxiety, but I haven't had the tools before to actually figure out how do I make this work for a child and a family. So in my practice, I screen a lot of kids at the beginning, and they may have mild depressive symptoms or some difficulties with self-esteem. And rather than actually engaging them in psychotherapy, my first step is to really talk to the exercise specialists and say, you know, what can we do with this kid? Because likely for a lot of kids, getting them active is going to be that thing that's going to take them over, and they're not going to have that mild depressive symptom anymore. They're not going to have that self-esteem issue. But then at the same time, we wind up with a bit of a chicken and an egg conundrum with getting kids physically active because they might have low self-esteem related to their body's abilities. So that could be the thing that's keeping them on the couch, that's not getting them moving, which is then also contributing to the depression or to the low self-esteem or to anxiety. And then you compound that by the fact that these kids may not perform as well at sports. There can be some bullying, some peer victimization, and you wind up with a lot of factors that are keeping these kids inactive. So one of the biggest struggles we have at our center is, you know, which one do you address first? Do you address the self-esteem? Do you address the activity? And then, once you're doing that, once you figure that one out, which I don't ever think we do it the same way twice for any 2 kids, the next step for us is figuring out, and I'm just going to collect myself, how do we get them the social support to keep this going? Because a lot of these kids don't have that social support out there. So they've got barriers to physical activity in terms of how they view themselves, and then also in terms of peer relationships. And then the last thing from pediatric psychology perspective, I really focus on families, because families are the support networks for kids. And what we've seen in our center, just kind of in terms of qualitative stuff, is we've seen families working to get physically active together. And the families are saying, yeah, we're enjoying it more, the kids being more active, but the families are also functioning better, and they're starting to say things like, we're gelling as a family, we get along better, we're not fighting as much. And that has a huge impact on the overall family structure and then on the self-esteem of the individual child. So I think there's a lot of interplay between physical activity and mental health for kids. I think the problem is figuring out where do we start working with them and how do we give them the skills to feel comfortable doing that physical activity.
Hi, I'm Brenda Fishbrook-Benoit, and I'm an occupational therapist that works at the Glen Rose Rehabilitation Hospital, and I work with seniors in psychiatry. So some of the barriers that we see with seniors are, first of all, their mobility. The average age of the person that I work with is 80 years old, so a lot of the people that I'm working with are in wheelchairs or they have walkers to be able to mobilize around. And so getting over some of those physical barriers, what are some of the things that we can do as occupational therapists to be able to adapt some of the activities that they could do so that they can do bowling rather than, if they can't bend and things like that, that we use little troughs that they can roll the bowling ball down to be able to play bowling, things like that. Some of the other things that we can try to do to get them more active. I think because of the depression as well, one of the things that we always try to promote in the program that I'm on, which is interdisciplinary, is getting patients out of bed. Again, with depression, everybody wants to stay in bed. They don't want to move, that kind of thing. Getting them up and going, and we have lots of, the first things that they tend to do or whatever in the morning is to go to our exercise program. Again, because of the mobility problems and the frailty of the patients that we work with, you can still exercise sitting in a chair, and we do lots of chair exercises, and then we can grade them depending on as patients get healthier and their endurance improves as they participate in the exercise programs. We can grade their activities to make them more and more.
I'm Beth Evans, and I'm a little bit different kind of practitioner in that my role is to lead some initiatives across the province that promote mental health and address stigma related to mental illness. A couple of ways that we've been working on the connection between physical activity and mental health is that we've been focusing on resiliency a lot in the work that we do, and we really believe the two are quite tied together. In any of the materials that we develop, we actually look at the whole lifespan. We've done some work for parents and caregivers of preschoolers. We're working on a book now for resiliency for children in the early grades in school. We have a magazine for youth that goes out to the junior and senior high schools across Alberta that's focusing on mental health, and it includes a lot of physical activity kinds of tips and ideas interwoven into the messages and the stories that the youth actually create. We've also done some workplace activity, information and resources for people, and most recently we've also done a resource for seniors that looks at staying well and healthy mentally as well as physically. Another way that we do our work is that we try not to work in isolation, and one of the roles that I have is as co-chair with the Alberta Healthy Living Network, whose priorities include active living. And in that, the work that we've done in the last couple of years is that we have taken a look at the key messages that can be used by practitioners, and we created key messages related to mental health specifically, and then we also created messages that talk about the benefits of physical activity and mental health and how they work together, so that there's a common understanding across all of those disciplines. And finally, there's another opportunity coming up for building that bridge between physical activity and mental health, and that is that Alberta Health Services has just created an organizational structure that includes population and public health, and within that, there will be room for addiction and mental health, healthy eating, active living, all of the things that go into preventing chronic disease. That feels like a major opportunity upcoming.
Thank you. Hello, my name's Emma Rickard. I'm a registered social worker, and I work at the moment as an EAP counsellor with Organisational Health Incorporated. Organisational Health Incorporated is a disability management and EAP program provider based here in Edmonton but working across Canada. And the essence of it really is that it's an employer-provided program that allows employees access to short-term counselling services. And really the take-home message that we try and give is that early recognition and treatment really is the key to preventing far more serious difficulties. The majority of the people that I work with are in the workforce, and I guess you could characterise them as the worried well. They perhaps haven't yet met criteria for more significant, for a formal clinical diagnosis, but certainly are vulnerable and are experiencing difficulties that are impacting on their functioning. Almost all of the people that I work with have self-referred to our service, which makes a difference in the work that we can do. Some do fit the criteria for mild to moderate depression. A very small proportion of these would have been formally diagnosed. Some are recovering from a more major depression and are perhaps on their way back towards good health and looking at reintegrating back into the workforce. This population really are ideal candidates for resiliency training, for mental health education and promotion, alongside working with them on the presenting counselling issues. And I think that when we're working on change with people, it makes absolute sense to start with the very basics, which are diet, sleep and exercise. Without healthy nutrition and good sleep and regular exercise, everything is difficult. So if we can start with getting these things in place, then people are a much better placed to address their other specific issues. I find that the majority of the people that I work with are fairly well informed about recommended daily activity levels. The majority of them are well aware that health is holistic, and that if you make a change in one area of your life, that it's going to impact and lead to improvement in other areas. For the people I see, I don't think it's education and information that's the barrier. The people I see range from the inactive to competitive athletes. And most often, rather than lack of knowledge, I think it's motivation that becomes the issue. Motivation being the getting started and then the keeping going. There's a big difference between knowing and doing, and we know that people struggling with depression find this particularly difficult. And we know that the benefits of exercise and fitness are really transitory. When you stop, you lose it. So for these reasons, I find that a motivational interviewing model is a really wonderful tool to work with people to explore their ambivalence, and rather than persuading or pushing and bullying, which more often results in people digging in their toes and resisting, to be able to acknowledge people's ambivalence, that there are good reasons for them to make changes, but also really good reasons why they might not want to, is a respectful and empowering way to assess people's readiness for change, to identify the necessary steps to enable change, and to highlight strategies with which they can maintain change. I really envy the story I heard of a GP who simply said to her patient, "Go and buy some running shoes," and the patient did and had wonderful changes in her life. But my experience tells me that more usually we really need to invest time to work through the personal roadblocks an individual is experiencing that stops them participating in physical activity, because I find that even once they're persuaded cognitively that it's a good thing, we need to go a little bit further to enable them to participate. Thank you.
Thank you. This one's on high. That's okay. So we will open up the floor for questions if anybody has any questions for any or all of the panelists. And I will welcome the panelists if one person responds and you have thoughts on that issue as well, to please jump in. It's more of an interactive discussion. And again, if you can go to one of the mics. And we have somebody moving. That's always a good thing.
I'm a psychology student. I study out in New Brunswick, and I'm about to start my honors thesis this year, exactly on the subject of physical activity and mental health. I'll be the only student in our faculty studying anything like that. But I was wondering, we were planning on looking at how often medical practitioners prescribe physical activity and what system they have to get their clients to use physical activity. So I guess I'm directing my question to Emma and Rachel, in the sense that, Rachel, you've worked in places where you couldn't or didn't have networking with sports or physical activity specialists. How do you, there's a lot of licensed psychologists out there who are by themselves. They have their own clinics. They're not in a hospital. They're not in maybe prisons or somewhere where they could have a large network. What do you do?
I think my previous experience has been going out there and looking for the information and figuring out what's available in your community. Here in Edmonton, for anyone who is looking for that information, WeightWise has the community network. And so people can just log onto the website. There are programs that have been approved for both physical activity and nutrition. And they can log on. They know that these programs have gone through a rigorous process to get approved, and they can use them. I think it's one of those things where actually Google can be one of your best tools in figuring out what is available out there in your community, and then picking up the phone and calling people and saying, what do you offer and how can you help my population?
Sorry, I also have used WeightWise. It's a fantastic community resource, and I guess I'm in a fortunate position in that, as I said, the people I work with generally are in the workforce, and that enables them greater access often to resources that have costs associated with them. When I was working in New Zealand, there was a real trend there to get GPs to literally make prescriptions of physical activity and rip it off the pad and hand it over. And I think there's something tangible like that. It feels more like this is not just a maybe, a nice to do. This really has as much validity as anything else that I write on this pad. And I think that's a nice idea, but I haven't heard of it happening here.
Actually, I'll jump in. The Canadian Society of Exercise Physiologists, or CSEP, they work with the Be Fit for Life units within Alberta. So if you call the provincial fitness unit, they can direct you. And CSEP has been working to do a similar prescription pad within Alberta. And there used to be a fantastic program put forth by Health Canada called the Go for Green. And they also had a prescription pad that if you Google, you can still find. But that prescription pad idea is certainly working, and CSEP is certainly working towards that, as well as ACSM, the American College of Sports Medicine, is also working in the same area. So, yeah, the Google generation is fantastic. All right.
Thank you very much.
More of a comment than a question. I'm a recreation therapist. I work in the community mental health, and I think, Emma, your point about the motivation is the big factor in the dealing with the people that I deal with moderate to severe mental persistent illnesses, and the motivational interviewing model we have adopted, and that has shown benefit in motivating individuals. But I think in the earlier talk about giving them a prescription to go to a program, it just doesn't, in my experience, it doesn't work that way. It's about building a relationship with the individual. Many times I spend my time just going for coffee to get to know them, and then slowly that progresses to something bigger, like the running shoes, and then it goes down, and then it's up and down, and it's not a linear thing. And I think that's something that we all need to consider. It's a long-term process, but it's been some great information. Thanks.
Thank you. I saw a lot of nodding when you made that comment. I'm wondering if anybody wants to reply to that or has anything to add. Yeah, Guy?
Can't believe I'm sitting next to someone from New Zealand, so you can see why I'm kind of slightly like this. No. Yeah, I mean, I certainly make a distinction between people with severe and enduring mental health problems, which perhaps you're referring to, and maybe perhaps a lot of the evidence that I talked about was more about mild to moderate depression. So people that we may come across, maybe the worried well to a certain extent, but people with perhaps less persistent and enduring mental health problems. And I agree certainly in the work that I've done that more actually with perhaps the client group that you're talking about. It does take a lot of time, and it's quite often it's about keeping one's own motivation up as a therapist in terms of trying to get across some of these messages. I also think that it's particularly for that group, we've certainly done some work looking at psychiatric settings as well, and how they have been, for quite valid reasons or historical reasons, developed in such a way to stop people from being physically active. and certainly at the Centre for Addiction and Mental Health in Toronto, they're certainly trying to redesign the facility in a way where people are more habitually physically active. So moving away from trying to motivate people to actually getting people to be naturally more active without thinking about it. So there's that side of the coin as well, that I don't think with some people with, for example, schizophrenia, it may unlikely to be successful, but there are maybe other ways to reach that group through broader environmental interventions as well.
Anybody else want to?
I think one of the advantages that I have working on an inpatient unit is that milieu to try to get people going. Once they are hospitalized, again, they're clinically depressed. Trying to get them going or whatever with the milieu of the environment that they're in helps them to kind of get going little by little. And then what we often rely on with our recreation therapists that we work closely with is once they're discharged from hospital, trying to get that same kind of motivation or encouragement or follow through once they go into the community once they're discharged.
Good morning. My name is Rob Crooks, and I chair the advisory board for the center. So just a big thank you again to all of the panelists for joining the forum this morning. My question is an open one to the whole panel, and it goes back to Minister Adie's comment, or I guess invitation this morning, knowing that they've worked on a couple of other agendas in her portfolio, and now the area of physical activity is sort of coming to the forefront. So, as practitioners sort of on the front lines in a variety of sort of community forums, what are your thoughts or ideas or opportunities that you might see in terms of taking her up on that invitation to move sort of from research to action? So I'd welcome your comments.
Again, sitting right next to the microphone, bad idea. I think from the perspective of the center where I work, one of the biggest issues we have is accessibility, and it's not just accessibility to facilities or to activities. It's really accessibility for the whole family, because if families wind up having to run kids in different directions, that becomes one of the biggest barriers. If a family can get together and be active together, that's one of the things that I think is really going to help us move this along. And if it can be done within home communities, if it can be something that's low cost that families can meet at a park and do together, I think that's a direction that we as a center would like to pursue. And actually, we've been very lucky to have a personal training studio working with some of our families right now for free to train them to do the Little Big Run next weekend. But if you go out to where they're training on a Wednesday night, what you see is a group of families and kids playing. And there's not a lot of cost to it. There's somebody kind of organizing games, but it's right there, it's in the community. And if that could be something done within individual community leagues, I think that would be a pretty low-cost alternative to get the entire family active.
I really think that that whole idea of moving into the community is actually very important, and I think that for the work that's come out of the Healthy Alberta Communities actually might be a learning opportunity and a demonstration, really, of what has worked and what has not worked. I think that's one way to turn that research into practice.
I think I agree with what you were saying, that any part of the barriers are capturing the people and where they are at that time. And I guess anywhere you have a captive audience, like in a school setting or in a workplace setting or in a hospital setting, it seems to me that you're perhaps halfway there. So any programs that are based around those organisations where people are already there in a group just removes so many of the barriers rather than trying to capture people one-on-one. So it makes sense to me to look at those kind of organisational settings.
And I think also, as I kind of raised in my presentation, it's this moving, developing the evidence base around effectiveness. So what kind of actually works in real world settings, and there's a great, well, I don't know if it's great yet, but the Canadian Mental Health Association are just developing a pilot project in Ontario, which is really about developing physical activity programs for people with mental health problems. So they're taking the evidence base and assume, okay, exercise is good. Well, how do we get mental health professionals and leisure professionals working together in terms of actually delivering these programs? So they've set up a couple of or 3 pilot sites where they're trying to develop intervention packages and manuals that can then be disseminated to other mental health professionals and exercise professionals. So that's the kind of research that is now required. The more applied research, which perhaps doesn't have the same rigor as empirical evidence, but it's demonstrating proof of principle in some way.
I used to work at what was formerly known as PDAC, and I now help the Ministry of Health and Wellness. I just was wondering if any of you were aware of any research on concurrent disorders and using an exercise regimen. Those are typically our clients that are a lot more serious with a severe addiction and a severe mental health disorder. And I haven't had a lot of success in terms of, finding out research and whether or not exercise is of benefit to this group.
So I just missed the first. Eating disorders, did you say? Or
Concurrent disorders.
concurrent disorders. So something like schizophrenia and an addiction to a substance?
Yeah, the domain for clients with severe clinical depression and a severe addiction, for example.
No, I don't. I believe there has been some research looking at alcohol addiction and people who also have a mental illness. But I think there's been a range of conditions alongside alcohol addiction. So I don't know if there is, but there's certainly lots of evidence that is, well, not lots of evidence, but evidence that has looked at the role of exercise in helping people with addiction. So people smoking, and less research looking at alcohol, and even less research looking at drugs. So I think you could potentially make a case that exercise could be play some role within that, but I don't know if necessarily the evidence is actually existing there to suggest that exercise is beneficial. But I think given the physical health issues that the population is probably also dealing with, then I think you'd have a strong rationale to integrate physical activity within that anyways. But I like, in terms of addictions, using exercise as a coping strategy for cravings. So we use, for smoking in particular, instead of having a cigarette, going for a 5-minute walk seems to help people, that kind of thing. So you could integrate exercise as a coping strategy for dealing with some of the cravings.
Thank you.
Oh, we have another question.
Hi, my name is Ellie. I'm with Edmonton Public Schools in the area of disability management. One of the barriers that we come up against is staff who are stressed. We get a prescription pad. I really like the recommendation here for a prescription pad for physical activity, because very often there'll be the medical note that says this person is off for stress-related reasons. They must rest for 6 weeks. And the interpretation of resting for 6 weeks is don't bother me, don't talk to me. I'm going to be in bed for 6 weeks, and at 6 weeks plus 1 day, I'm coming back to work. I'm going to do everything I did before and everything in my in basket, and it's totally impossible. So somehow, what advice can you provide for us as the disability management team to say, yeah, rest? And I think it's a whole paradigm shift as to how we communicate recovery. But do you have some advice?
Does anybody want to take that one on?
I think it's perfect. I think it's helpful for both you and the person to have a slightly more elaborate return to work or healthcare plan than just rest. I agree with you. It's very vague and it doesn't set very clear expectations for you or for the person. What are the steps they're going to require? Are they required to go through in order to return to improved functioning and therefore be able to return to work? Or as an employer, how can we, it doesn't give you any information, but how can we assist either with perhaps modified duties or reduced hours this person for a successful transition back into the workplace, which is what everybody wants. And I wonder sometimes if GPs are in that difficult position where they're wanting to protect the privacy of the client, or perhaps don't feel it's their area of expertise to think about that kind of comprehensive treatment planning. So I think there's really room for a dialogue there between all of those parties, and there's quite a lot of literature around about this now, about having a really cooperative and integrated approach of all of those parties in developing a plan from how do I get from here to good health and back to work.
And we actually do have that with our medical form that we recommend our employees use. We would never ask a diagnosis or anything, but we do ask for what are your capabilities and at what point. And we certainly stay in touch with the individuals. I guess it's more of the hardcore, and maybe, you know, it's the underlying reason for the stress that maybe needs to be investigated a little more. But
actually, can I follow up and ask you, in general, how are the employees responding? Do they feel that what they really need is 6 weeks in bed? Like, is that the underlying feeling, or how are they approaching their own recovery?
some don't. And those who are open to recovery programs, such as you recommended, Emma, that lays out, you know, the next 6 weeks will look as thus, and sort of plan it out in the graduated return to work and the modified work that we certainly do have. It's more the hardcore, and maybe that's the wrong term, but the ones that really prefer not to discuss anything for a period of time. And but from what I'm hearing, we're probably on the right track. It's just encouraging a little more dialogue. Thank you.
Thank you. Are there any more questions?
Good morning. I guess I have more of a comment, and a big thank you for Dr. Faulkner. I'm a recreation therapist. I've worked both in mental health and with the geriatric population, and it's really a great validation to see in print research that says what recreation therapists are prescribing, and some of which is physical activity, really does work. I think a lot of recreation therapists and occupational therapists who work in mental health settings and in geriatric settings anecdotally see the benefits of physical activity. I've worked with patients with moderate to major mental diagnosis and many diagnoses. And when we see people who get active and are less aggressive, affect is much brighter and much better. It's just such a great validation of what we do. But to see it in print is excellent. And I'm really hoping that the Alberta Centre for Active Living is going to have the Mental Health and Physical Activity Journal available, because there's some great stuff there that hopefully will help us to provide even more programs and more benefits for our patients. So thank you.
I'll ask Roseanne, does the centre already subscribe to that journal? Oh,
I'll give you a discount.
Oh, Roseanne has left the building. Oh, there we go. Does anybody else have any questions? Oh.
Hi, my name is Ivan. I'm a doctoral student here in the phys ed faculty. Actually, two quick questions. First one for Guy. There's research being done in diabetes and cancer looking at comparing resistance training and cardiovascular training and its impact on the well-being of the client. Is something similar being done with people who suffer depression or some mental illness? And if so, what are the results?
There's been, some interest in comparing different types of exercise and its impact on depression. Typically in the meta-analyses, again, which can kind of figure out, are there different effects for different types of exercise. Generally, there's no difference. And that again implies to me there's something about the mechanisms that are very broad, that people get different things out of different types of exercise. The only where I think there is difference is the focus with older adults, and certainly there is some work suggesting that strength training is very important for older adults in terms of an antidepressant effect as well, which is probably in line as well with why we prescribe, for older adults a combination of strength and aerobic exercise, that maybe it has an impact on fear of falling, or it has an impact on maintaining their functional independence, which then has an impact on their mental health as well. So I think overall there doesn't tend to be any major differences between different types of exercise, but I would say for older adults, research suggests that strength training is an important component.
Okay, thank you. And a quick question for Emma. Within the workplace, how motivated are people who maybe are dealing with severe stress issues or depression to actually come forward in the work environment to seek out assistance?
I think it varies hugely, and I think it's largely dependent on the culture of the workplace. And I think managers and supervisors and employers have an enormous, they really set the tone and the culture in all sorts of ways in a workplace with regard to promoting the good health for their employees, dealing with issues of stigma, dealing with issues, setting the tone regarding harassment or bullying. I think that we need to support employers more, perhaps, in helping them understand how significant that is, and how we can support them in really sending out a message that this is really important. This isn't just an optional, a nice to do, an extra, but this is a critical component in you being a healthy and complete person, and therefore a good employer and good employee to us.
Thank you.
Okay, I don't see any more questions. What I'd like to ask each person on the panel to address, if possible, is, given the work that you do, if you had a magic wish list and there's one thing that you could wish for to make your job easier in integrating mental health practice and physical activity, what would be the thing that you would want the most? And I won't hand it over to Rachel, I promise. So I'll start down at the other end if that's if anybody wants to tackle that. If there's one thing that would really make your job easier, what would it be?
Well, I'm trying to think. I mean, the type of research study that I would like to do, particularly just to focus back on exercise depression, is looking at what I believe is known as this treatment aptitude interaction issue. And essentially that means, how do we identify who is most likely to benefit from an exercise intervention as opposed to medication or therapy? And I think that would be an important study to do, but that I think would be particularly important for clinicians so that they can be selective. I don't think exercise is necessarily for everyone in terms of depression. I would say that there are still good reasons why you should promote physical activity to clients, but I don't think necessarily everyone is going to experience an antidepressant effect. So how do we identify those people who are most likely to benefit, so clinicians can be ration their time and so on in terms of making that referral? And I think we have some general sense that at the least it's probably people who've often enjoyed physical activity or sport when decades ago, and somehow for whatever reason they've lost touch with that hobby or interest, and reactivating that is maybe a powerful experience. But there's probably some other factors out there. So that's what I'd like to do. My wish list would be to do a big randomized controlled trial, but also looking at some pragmatic issues. So not necessarily the efficacy, but how do we deliver this in a real world situation, but how do we identify those most likely to benefit?
I think I would wish for every workplace to have an active living component that's just part and parcel of the day at work, and an expectation and accessibility for everyone to take part in it.
I was thinking about the conversation near the end of your presentation on about how we need to link physical activity knowledge with mental health knowledge, and I was thinking about courses that I'd taken, and not one of them really touched on physical activity, which is kind of amazing in retrospect. So I think to make that link, I would like to see more opportunities taken even in the academic settings to make sure there is that kind of cross-training and education. I think that would go a long way to a holistic look at how we deal with health and promote health.
I think with such pressures that we have on the hospital systems now, more and more they're trying to get patients out of hospital as quickly as possible because there's waiting lists and waiting lists. And Dr. Faulkner alluded to that sometimes it takes 12 weeks or whatever for someone with a mental health issue to be able to get into hospital. I think trying to promote more services in hospital as well as those community services outside of hospital so that the work kind of starts on an inpatient basis, but it needs to continue when patients leave. So other programs, community-based programs, development of those, and having more programs and easier access for people of all ages so that they can continue on with their physical activity or being as active as possible to promote their mental health.
This was a hard one because I think I have lots and lots of wishes in this area. But I think when I think about the kids that we work with and the ones who get really discouraged with physical activity, I think a lot of it is when they're in certain physical activity situations, they don't perform as well, they don't feel as confident. And so I think my wish would be for there to be different programs, particularly within schools, within communities, that kids could get involved in who may not traditionally be into sports, but might find a strength in another area, and for those programs to be open to kids at younger ages, because a lot of the 8-year-olds we see may not want to play soccer, but they might be totally happy doing something else upstairs in a gym that's off limits to them right now.
Okay, so I'd like to thank all the panelists. This has been really interesting, not only in the integration of the mental health and the exercise, but also the research to practice piece that Beth just identified, and is quite challenging. I was in a meeting recently where it was a big jumble of practitioners and people and researchers, and one person who works out in the field said, "Oh, academics are so cute. They have their models and they lecture on these models and they talk about these models, but when you actually try to implement it in the real world, it's often a bit of a struggle." So I really thank the panelists for talking about how they are doing this very valuable work out there in the community with people who genuinely need their services. So thank you very much.